So one request, if you can speak louder so that we can have the sound. Same sir. Focus our output.
Okay. Good morning. My name is Maria Ruiz. And first of all, I would like to thank Biotech for having me here and to be given the opportunity to learn from all of you. So with this said, let's start. First of all, we're going to have Professor Dr. Alper Agca, and he's going to be talking to us about the prevention and management of complications. So good luck.
Dear moderator and colleagues, my presentation is on EYECRYL lenses prevention and management of complications. The most important problem with any posterior chamber Phakic intraocular lens is correct sizing. So, in theory, the sulcus can be visualized with uvea, and the diameter of the horizontal sulcus can be measured preoperatively. However, during UBM measurements, the position of probe is adjusted manually, so you can never be sure of the exact location of the measurement. The image quality is low, and it's not clear how to use sulcus measurements because there is no nomogram to use with it. In addition, the greatest diameter does not give you the correct two-diameter sulcus shape because the sulcus is not circular. So two eyes with the same horizontal sulcus diameter may need different intraocular lens diameters. So even if we have the technology to visualize the sulcus, it's very difficult to estimate the correct sulcus size and to use it. However, in clinical practice, this is rarely a problem because there is a very broad range of postoperative intraocular lens volt. Because postoperative intraocular lens volt is acceptable in most of the cases if it's between 200 to maybe 600 microns. So the solution for this problem is to use a nomogram supplied by the company, but still rarely with any kind of posterior chamber lens, you will rarely encounter an unacceptable volt. So the real solution is not to hesitate to change the intraocular lens if it does not fit well, because it's not a difficult surgery. You should be familiar with it, and you should not hesitate to change it because it's easy and it solves the problem. A low volt may result in an unstable moving phakic intraocular lens, and the high volt may cause light disturbances, discomfort, and inflammation. In case of a low volt, if the lens, I do not look at the exact numbers, okay? If the volt is, if the lens is not stable, it's rotating, I change it. In case of a high volt, if the volt is high and the patient has any discomfort, halo glare, or inflammation, then I change it. I do not measure the distance and decide to change it or not, depending on that measurement. I look at the clinical picture. I'm sorry. So, if I decide to make explantation, how do I do it? The first step is to take the EYECRYL to the anterior chamber under viscoelastic and using a push pull. You can do it from side ports, or you can do it after you open the main incision. You should have a 3 to 3.5 millimeter main incision. Here you should go a little bit higher, because here the main problem is not astigmatism. You should take out the lens without a problem, and a small amount of astigmatism is acceptable, so that you don't have problem in surgery. So do not try to, it can be done from 3 millimeters or lower, but do not try to do it. Make at least 3.5 millimeter main incision, maybe 4 millimeter, it will not cause any problem. After positioning the lens in the anterior chamber, you should grasp the lens with a toothed forceps, and you should pull it outside while supporting from the side port. Here is a video. Okay. You should not need to put these this part of the lens in the anterior chamber, but this part should be, these haptics are above the iris. This part is below the iris. You should grasp it from the optic because this is thicker. And you should not support from conjunctiva because it will tear. You should support from the side port. And if this is 3.5 or 4 millimeters, it's very easy to explant it. So you can use viscoelastic again and put the new lens in. It's an easy surgery, so if you have any problem, do it. Another problem, maybe not a complication, but another problem is near vision. This should be discussed with the patient before the surgery because although some patients, authors advocate for a slight undercorrection in high myopia, I don't aim high undercorrection because there will be regression and axial elongation in long term. So instead, I explain to the patient that near vision may be a little bit worse after the surgery, but this will be better with time due to regression. But the patient does not want to experience any near vision problems. You should aim for slight myopia. So you should discuss it with the patient because if you do not, after the surgery, you may have problems with the patients. Okay? Another complication is uveitis. You can't do anything to prevent it. It's very, very rare. It can be, you can see it with any kind of intraocular lens implant, anterior chamber, posterior chamber, in the back. Uveitis may be seen, and it will always respond to steroids. If you I usually see it during the first month when we start to taper the steroids. Sometimes there's a mild reaction. It's not a problem. You should increase the dose of the steroid, maybe hourly, and it always resolves. Glaucoma, in long term, I have not seen any glaucoma patients that require surgery, but in theory, any posterior chamber or anterior chamber phakic intraocular lens can cause inflammation, pigment dispersion, and it may result in glaucoma. Maybe one important thing is that pupillary block after the surgery, after the early postoperative period. This is a phakic intraocular lens with an old design. It doesn't have a hole in the center. After the surgery, there's pupillary block, and this is preoperative. So, in the new designs of phakic intraocular lenses, posterior chamber phakic intraocular lenses, there is a hole in the center to prevent pupillary block, but this pupillary block develops in the first few hours, okay? And during those first few hours, this hole may be blocked by viscoelastic. So there is still a risk for early pupillary block. So I personally do not give myostat during the surgery. So because I want this area to be open and work as a peripheric iridectomy. After a few hours, when this is closed, this will be open. So to make the surgery, to make the pupillary block risk lower, I do not give myostat, and I personally do not see any advantage of constricting the pupil after the surgery because it causes pain, headache, it causes myopic shift, so you cannot estimate the correct postoperative refraction, and it also increases the risk of angle pupillary block glaucoma. So after the surgery, I do not give myostat and leave the pupilla dilated. And cataract, in fact, the two main problems of posterior chamber phakic intraocular lenses are sizing and cataract. Those are the main things that we are afraid of. Sizing is, in my experience, not a big problem because it's very rare and I change the lens. Cataract is very low, cataract rate is very low. Again, it's not a very big problem. Why? It usually develops in years. Okay, it may develop earlier than the other patients maybe, but it takes many years to develop. And after it develops, you can still make cataract surgery. So the patient will still be free of at least distance glasses, and you can make a little myopic. You can make the patient a little myopic. Cataract is not a real problem, I think, because still the refraction will be good after cataract surgery. And this incidence is, in my experience, very rare. I had 4 patients with cataract surgery in about 700 cases, so it's low. But it may still occur earlier when compared to normal patients. Another problem is haptic entrapment. During the surgery, it may be seen in these lenses or other lenses. There is a video of it. If the haptic is trapped in this part, it may be during phaco surgery, this surgery, any implantation. If the lens injector is plastic, I usually cut this with an electric coater. You'll see it. Now it's stuck here, so I'm going to cut the injector. And when this silicone plunger goes up, it's okay. It's an easy solution. You can use it during cataract surgery also. In conclusion, be careful while deciding for the smallest and largest size of the intraocular lens, because problems are usually with them. If you use the largest size, the volt may be higher, and the smallest size. Consider long-term emmetropia versus early-term patient satisfaction for near vision. Don't forget that EOL exchange may be necessary, and it is a normal part of this surgery. Don't hesitate to do it if you need it. It's not more difficult than the first surgery. Glaucoma and cataract are not common complications. Pupillary block may still occur, so I don't make miosis. And keep the patient under observation for the first 2 or 3 hours. I don't send the patient directly to home. And in the first day, most of the patients say I have problems with near. That's usually due to adrenaline and cycloplegia during the surgery. In cataract patients, you don't see it because they are pseudophakic. But these patients are phakic. And you give cycloplegia before the surgery, adrenaline during the surgery. So in the first days, their near vision problems are a little bit exaggerated. So talk with the patient. And thank you for your attention. Sorry?
When you implant an EYECRYL lens,
Yes.
what would be your desired bold?
What do you mind?
Your desired bold.
Desired volt? Nobody knows the ideal volt. Okay, ideal volt is the volt that does not cause problems. Okay? What are those problems? Shallow anterior chamber and cataract. If the lens is not very close to crystalline lens, and in literature it's usually below 100 microns is seen as a risk for early cataract. So if it's not below 100 microns, it's above 100 microns, and the anterior chamber is not shallow, then that's the ideal volt. Okay? Not very close to crystalline lens and the deep anterior chamber. That's usually something between 300 and 500 microns.
Into consideration,
Sorry?
do you take into consideration the patient's age, for example?
As the patient gets older, the crystalline lens volt gets higher and the distance gets shorter. But the studies in the literature about that issue, they are not evidence-based. Okay, we don't know the exact numbers, etc. It will take a very long time. And if, of course, it's below 100 microns, this may be a problem. But if the distance is something like 300, 400, I don't think that it will be a clinical problem. But yes, the lens fold gets lower with time.
And would you feel safer with a bolt of, for example, 150 or a bolt of 800? Which one would you prefer?
The safer.
Which one would you prefer? Which one would you feel safer with?
Safer volt, about the volt.
With 150 or 800?
For high volts, I look at the anterior chamber. For example, if the volt is 800, but the anterior chamber is still very deep, then that number does not mean anything. If the anterior chamber is shallow and volt is 400 microns, that 400 microns is a problem.
Really high.
So they are different. With 100 micron, I'm always not happy.
Okay.
But with 400, 500, 600, sometimes you can still be happy.
Okay, thank you. Do you think the same?
Oh, yeah. Yeah, so for toric ICLs, it's better to have a slightly higher volt because if you have a very low volt, if it's a spherical ICL, most likely, because even if it rotates, it's not going
Yes,
to cause
rotation,
problem.
low volts.
So,
Yes.
so in toric ICLs, I would be happier with a slightly higher volt because there's less chance of
Yes.
rotation.
Exactly.
Spherical, I wouldn't worry about 100 microns.
Thank you.
Okay.
Okay, I think
Do
that's
you have any
okay.
questions?
And why do you think the peripheral holes are important in the lens?
I can't hear.
Sorry. Why do you think the peripheral holes in the EYECRYL lens are important?
The peripheric holes.
Yes.
I don't know. The peripheric holes are not important in my opinion, but in theory, it increases the circulation. It makes it easier. The circulation of aqueous humor. And it is said that it's believed that those aqueous circulation, a better aqueous circulation, decreases the risk of cataract. But again, that's not evidence-based. Okay, we believe that, but we don't know it. We believe that blocked aqueous circulation increases the incidence of cataract, but that's not evidence-based. But making holes in the lens is not difficult, so we do it. And it provides better aqueous circulation, and this may decrease the incidence of cataract.
And does it also help with the glaucoma prevention?
For glaucoma prevention, a hole under the iris will not prevent it because the block is after that in the pupillary zone. The peripheric holes will not prevent it. The central hole is of course very important because you may pupillary block in long term also if you don't have this hole in the center. So it's very important. But the peripheric holes just increase
Not so
the aqueous
important.
circulation.
Okay.
And
Thank
may
you so
decrease
much.
the incidence of cataract.
Thank you, Dr. Agca.
Question for him.
Yes.
Have you started using, instead of UVM, have you started using OCD for the lens size and for the sizing?
For lens
ASOCD?
sizing,
For lens sizing, have you considered using, other than UVM, nowadays they're using the ASOCD?
I never use UVM because I use UVM for different purposes very often. Okay, and I know that because
It's very
during
tough,
the
I agree.
it doesn't have any meaning. Those measurements, it doesn't have any meaning. So I don't use UVM during before lens sizing. In theory, it looks good, but in practice, it does not work. So I look at white to white, etc. Those regression formulas. Okay, and about that white to white, I use IOL Masters white to white measurements. Sorry, I don't use IOL Master. I use Pentacam. When I use IOL Master, maybe it's more correct, it's better, I don't know. But when I use IOL Master measurements, it usually results in bigger lens and I have problems. I personally use white to white measurements of Pentacam.
Pentacam is very good, yeah.
And the correct white to white is not important. That's why I do not measure it with caliper. because I don't want to learn the correct white to white. I want to use a number that results in correct sizing. There's a small nuance there. I use pentacam.
Do you have any other question? Okay, so thank you, Dr.
Thank
Agca.
you.
Next, the next speaker is going to be Dr. Luthra, and he's going to talk about the morning after.
Is that mine? Okay, so this one? Sure. All good.
Yes, so no, it's so noisy, so I cannot hear.
I'm so sorry. I'm trying to speak loud.
Unless it doesn't make shallow angle.
Yes. They wanted me to ask you all about this, of the bold thing, so.
We don't have anything to know. There's no other port. Just use this one. This one? No?
We can run the slides.
Okay, yeah, I'll run it. Yeah.
हम कर लेंगे सर अगर
कोई नहीं. So, am I audible? I don't know if I'm audible, but can anybody check if my audio is clear? Okay, I'll speak loudly. So I don't think you can hear me with there's no headphones. Okay. So I have a patient who's 25 years old and with a refractive error of 7.5 and cylinder, and so we were planning this patient for a toric ICL, and the AC depth is 2.9 and 2.9. These are the white to whites, and these are the pentacams. I'll move it. Okay. So these are the pentacam maps. A patient was given option of both laser correction and ICL, and patient decided that he wanted to do an ICL after understanding everything. And nowadays for high corrections which are touching 10 diopters total including sphere and cylinder, we tend to always shift towards the phakic lens. So both historic ICL was planned right eye first. Post-op, first eye we had a vault of about 270. I don't know, it's not visible here, but what's the vault size? Okay, so it's 271 was the vault size. It looked fine to us. Went ahead with the. So second one was planned a few days later. It was an uneventful surgery, and post-op day one, patient looked like this. So he complained severe pain at night, and he said that he had been throwing up all through the night, and pressure was 70, and so pressure was 70, and he came almost like a retrobulbar hemorrhage. It was all kind of congested and with a lot of lid swelling. So we were not sure whether I'm sorry. Anyway, let's go. So we thought this was a vault. It was not a bad vault. It was about 500 microns and 566 microns. But you can see the chamber was a little turbid with a lot of reaction. Patient was 6'9". So it was the pressure which was like really high, and the pupil was mid-dilated. So it was not constricting even with pilocarpine and other things that we tried. We put him on mannitol and topical glaucoma medications, Dimox, and the works. And we looked back at the surgery. So we looked back to see whether we had done an adequate viscoelastic removal at the end of surgery, and we realized that we had done the usual adequate viscoelastic removal. We spent about 2-3 minutes removing all the viscoelastic, so we were a little concerned. This was like, we looked back, we record all surgeries, so we went back to see, and apparently that we had done everything right. So we gave mannitol, Diamox, and started on almost everything. By afternoon we realized that the pressure was not coming down at all, so we did a paracentesis burp. We burped the AC to bring the pressures down because it was still at 70, and with the burp the pressure came down to about 25, and then we continued the patient on same medication. Post-op day 2, the vision had fallen down to 636. There was a small central epithelial defect. Pressure was again 60 millimeters, and we were of course continuing all the medication. So we repeated mannitol next morning. Pupil was mid-dilated and not reacting to light because already it was on pilocarpine, had been used the previous day as well. So we decided to go in and see whether we want to explant the lens or maybe do an AC wash and just look for any tuck of the iris in the periphery with the foot plates or something which might be causing a problem. And we decided to go back and so we went back and we repositioned the ICL. We were trying to decide whether to explant it or not. We also stroked the iris in the periphery to see if there was any iris tuck, and then we went in and did a surgical PI as well. So the iris was very floppy, and it had, even with the intracameral pilocarpine, it did not really constrict much, and we decided to do a PI. So anyway, so we did a thorough wash and we did 2 PIs as well. Now post-op day 1, you can see the PIs over there, and the chamber is much better. The pressures had stabilized to about in the 30s. Pupil was still dilated, it wouldn't constrict. So 1 week, now gradually with medication and oral Diamox, pressures did stabilize. They came down to the early 20s, and gradually the patient was doing better, vision started improving, and the vault started falling now, in spite of, we were not doing anything. So the vault went down, and right now it is like 263, it's 263, the vault. And 3 weeks, at 3 weeks the vault is almost gone. It's like, we couldn't explain it, the vault was going down. So, I mean, we manage the patient now. The patient is about 2 years post-op, maintains a vision of about 6/9. The vault is almost, there's no vault. Patient was given the option of getting an ICL exchange and maybe a cataract surgery because there was early cataract. So after this case, we started using, First of all, I would like to ask, what do you think would have happened? Any guesses on what may have happened to this patient? So we think that it was like a Urette-Zavalia syndrome kind of a thing, where there was a pressure spike, and he was apparently vomiting a lot. So there was a lot of pressure built up, and maybe the IOP went up, and with that patient developed Urette-Zavalia. Has been reported. There are two other case reports following ICL. So we feel that Urette-Zavalia is a possible thing. I've been doing ICL for 20 years. I never saw anything like this, but this kind of prepares you to deal with this once in a while. So the changes we made in our systems. So now for last about 3 years, this patient was about 3 years back. It's not a new patient. We now use hydroimplantation for all our phakic lenses. We don't use viscoelastic anymore, and all our lenses are so we don't see any IOP spikes. We don't see chamber the vault fluctuations following surgery. So this is not an EYECRYL. This one is a star lens that I'm implanting, and that also happened. The complication also happened with a star lens. I'm now using EYECRYL lenses, but I've been using Star for many years. So now you can see that I have infusion on the side port. There's no viscoelastics. And I do this technique with all the other ICLs that I use as well. I mean, including Star, I also use it for the Biotech and the other lenses that I use. It's just that you have to be more careful that your chamber does not shallow and your incision size and injection technique is good. And of course, a beginner should not attempt this at all. But experienced surgeons can do this once they are happy with, I mean, they're comfortable with their injection and manipulation of the ICL. So the advantage is that we don't see IOP spikes and patient discomfort post-operatively and changes in vault. And we found that also at the end of surgery, we don't have to sit and do an AC wash for long periods. Positioning the ICL is fairly straightforward. So, and that usually does it. So IOP spikes can happen and we all see them. Following hydroimplantation, we've stopped seeing IOP spikes. Most patients on post-op day 1 or in the evening of surgery, they'll have pressures of around 20, I mean, not even higher than that. And good viscoelastic removal. So also I think it's very important to counsel the patients right. You know, we always end up telling them that ICL is a very safe surgery and you hardly would see any complications, and then, you know, if you have one patient with something like this happen, we have to kind of build the right expectations, and that was probably what I wanted to convey. He, you know, Mr. Khalsa wanted me to show some good complicated case, so I thought this would fit into the system, and so thank you. So any question?
And what happened at the end with the pupil of this patient?
Sorry?
The pupil of this patient?
The UBM was done at that time, and frankly the UBM showed that the, you know, the plates were sitting right at the desired position, because on the first, we had done the UBM on the first or second day of surgery when we realized, and we had to refer the patient. We did not have UBM in our hospital at that time. We have kind of tried 2-3 UBMs thinking that we'll do sizing, but because they are not predictable, so we didn't eventually end up you know, keeping the UBM. But the UBM done at another center showed that the foot plates of the lens were sitting at the right place. They were in the sulcus. We can't explain why the vault came down. The vault came down, and very fast. Within 3 weeks, the vault was down to other eyes maintaining the same vault, same size. Everything is the same. No difference in surgery.
No, it's a really interesting case.
It seems that intraocular pressure rise is due to pupillary block, because after you make a peripheric iridectomy,
It's held down.
it's resolved very suddenly. So the block is in pupillary area. If there's pupillary block,
Maybe that hole was blocked.
then
Maybe
the
feel
hole
that
is
the
blocked,
viscoelastic was.
and that's also in line with your vault, because after some time passed, your vault decreased, and that's in line with viscoelastic under the Phakic IR. So in my opinion, maybe there was viscoelastic under the intraocular lens. That's why the vault seemed normal, but it decreased after some time.
Yeah.
So it was viscoelastic.
We think it was viscoelastic because we think that the central hole may have been
And the reason
blocked
for
with the-
changing vault is also viscoelastic.
Right, but then in the other eye there was no change in the vault, and you know, post-op day 1, the vault was 500, and
and
it
probably-
wasn't as if the vault was like very high. 500 is
Probably
still
there
good.
was some viscoelastic.
Maybe some viscoelastic. So some viscoelastic will always remain. You know, you can do your best with the removal. You will never get 100% removal. A trace will remain.
There's always
Some viscoelastic,
But this time I think it was too much to block it, and also enough to change the vault.
What role did viscoelastic did you use?
So we were using methyl cellulose all the way. Nowadays, you know, many people have started using sodium hyaluronate because it comes out as a bolus.
I always use Provisc.
Provisc?
Other sodium hyaluronics do not come that easy, but Provisc always comes
out
out
fast.
very easy. And you can also watch it, see it, if there is viscoelastic or not. So that's why if you leave it, it causes more intraocular pressure spike.
So
But
now we are
it's
happy to
easier
actually
not to leave
not
it.
use any viscoelastic at all. We've stopped using viscoelastic completely. So we are comfortable, except that you have to be more careful with the surgery because chamber fluctuations are more likely, and if you have a lens which doesn't open correctly or something, then you have to inject viscoelastic anyway.
And would you have explant the lens, or you would have leave it like he did?
I'll definitely explant it because it was too low. I'll explant.
So that choice was given to the patient. He was so scared of any more surgery, he decided that he doesn't want it. In fact, by the time 3 weeks the vault went down, we told him that you're going to get a cataract with this vault because there was almost nothing
Yes.
left. And so since he did not want it, he said that, okay, if I get the cataract in a month or two, I will get operated anyway and then you can do my cataract surgery. See, the dilemma was that if we explant the lens, should we put in a new lens? There were already early cataractus changes, we could see. But it's been about 3 years, patient is about 6'12". His cataract has not progressed. It remains almost the same. He is in line for surgery, he's coming to us every 6 months and he knows that he has to go for a cataract surgery soon. But for now,
He's okay.
He's okay.
So-
I can give you a tip. I have the same experience, and there are some inflammatory particles covering the central hole. So in that case, you can use the laser to shot in the center of the hole. So there are many the aqueous fluid and the inflammatory particles can pass out. So intraocular pressure can be reduced dramatically. Yes.
I agree. We thought of that later. At that day we did not think of this, but later on in retrospect we thought.
Can you
So
please
did you use myostat after the surgery?
Not in the
No.
first setting, but when we went in for the AC wash, that time we used pilocarpine.
In this case, at the end of the surgery, the pupil was
a little bit louder?
So we don't normally use pilocarpine.
Okay, and our last speaker is going to be Dr. Kim Muyan, and he's going to talk about Glaze, the last resource.
Hello,
It's
thank
really
you for
difficult to
being
hear.
here. My name is Muyan Kim and working at GSI Clinic in South Korea. Today's my topic is about lens implantation, even inside narrow anterior chamber. You know that soft gel-wise material is easy to be inserted into an injector and easy to be manipulated inside the chamber. But if the reading haptic would be so flexible, it could not be safely controlled to go forward just underneath the corneal endothelium. And if the IOL would be pushed out so quickly, it might touch and hurt endothelial cells in narrow space. Sometimes we face really embarrassing cases. Highly myopic and patient with eagerness to take off glasses, thin cornea, and narrow anterior chamber. What do we have to choose? This candidate, yes, he is high myopic and not suitable for laser treatment. And his ACD is just 2.76 and 2.75. But because of job offer, he had to take surgery. Yes. How about Phakic IOL? Regardless of anterior or posterior chamber lens, ACD larger than 2.8 millimeter is essential. And some another types of company should request larger than 2.8. Surely it shows, we can find it very narrow anterior chamber on both sides. So I choose small size Glaze lens. Glaze is the commercial name of Biotech Phakic IOL in Korean market. And Biotech Phakic IOL composed of soft gel-wise material is gently be pushed out inside the chamber, and we can easily control it to rotate in narrow space. Of course, I needed a lot of viscoelastics and the pupil dilating agent. Anyway, I think I already inserted some brief surgery video, but now that is disappeared. Yeah. Anyway, just one day after surgery, fortunately, post-operative data was perfect. Yeah, it was fortunately, yes. And it made wonderful visual acuity within one day, and intraocular pressure was stabilized with no endothelial cell damage. So conclusionary, I would like to say, escape this kind of case first. Yeah, that is important. But if you should do, Biotech Phakic IOL might be the best result. Yes. I think, where is my surgical video? Anyway, there is no video. I already inserted oh. Okay, anyway, thank you for attention.
Okay, Dr. Yan. And what advantages would you highlight about this EYECRYL phakic lens in comparison with, for example, the other phakic lenses that are nowadays in the market, such as the ICL, the IPCL?
I actually experienced longer than 20 years. My 7 fellows have been performing toric artiflex and ICL and IPCL even. And in my experience, the material itself is very much important, and leading haptic design is much more important. Yes. So if the lens is so flexible, we cannot easily control to my direction, and we cannot go forward just underneath endothelial cells. And the pushing out speed is very much important. Sometimes injector using this, the Biotech Phakic IOL, yeah, that is sometimes difficult to use. And entrapment much more commonly happens than we expect. But it can push the lens slowly. I think that is important.
Thank you. And do you have something more to say? Or do you want to ask something?
Do you use a different AC depth cutoff for with your EYECRYL lenses, or the same like 2.8 or 2.9? What's your cutoff for the minimum AC depth?
Minimum is 2.8, yeah.
2.8.
But sometimes, in that case, like that case, whenever I choose many kinds of lenses, the Biotech Phakic IOL is #1 pick. I can trust it. Okay?
So that's all. Thank you for all of you. It has been a pleasure. And goodbye.
Thank you.
Thank
Pleasure
you.
meeting you.
Nice presentation.
Thank you. I've learned a lot. So thank you. Thank you.
Fotoğraf çekelim ya. Eve fotoğraf...
I want a picture, please.